Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, along with my beautiful wife, Janet, and our wonderful producer, Lindsay. And we are streaming live in the Moses Lake Professional Pharmacy Studio today in beautiful Moses Lake, Washington. And you can catch us here every Monday, 1 to 2 p.m. Pacific Standard Time, right here on my personal Facebook page and live on the Moses Lake Professional Pharmacy's YouTube channel. Also, catch us a day or so later when the podcast is edited and uploaded to your favorite podcast forums like iTunes and Google Play and SoundCloud and Stitcher and iHeartRadio. So don't miss us there. Listen there, like us, comment. Let us know what topics you'd like to hear, especially go to our YouTube channel. It is growing ever more. We have over 100 videos on there now, lots of different topics. So subscribe to our YouTube channel so you don't miss an episode, and please comment there and share. So today we would like to welcome Dr. John Sanders with Voyage DPC, and he is a DPC, which is direct primary care doctor. He, like all the direct primary care, has a membership model. You guys are familiar with that if you've watched our podcast, because we talk about it a lot. I'm a big believer in it. When you look at my book on Amazon, Sickened, How the Government Ruined Healthcare and How to Fix It, available on Kindle, soon to be available on paperback version and a audio version. I'm hoping by the end of the year that'll be done. We're busy working on that right now. But one of the fixes, and there's a 6-step solution. So the government ruined healthcare. Okay, I get that. But what are we going to do? Just whine and cry about it? No. Here at Health Solutions, Team Needham has solutions for things, not just sit and whine about problems. We have solutions. And there's a 6-step solution in that book of how we can fix healthcare. One of the fixes is actually direct primary care, and seek out direct primary care providers, because that is going to help healthcare be more accessible and better price. So, Dr. Sanders, why don't you tell us a little bit about your history and how you got into direct primary care?
Yeah, I'm John, Dr. John, and I grew up in a mining town in Nevada. I went to University of Nevada, Las Vegas for undergrad. I did sports medicine there, and then medical school in Florida and residency in Jacksonville, Florida. From there, I went to practice rural medicine in Moab for 6 years. Super fun, delivering babies, working in the ER, the hospital. And I've always been interested in the back end of medicine, which is the business side, right, and the finances of that. And I was a little bit frustrated when a patient would ask, "Hey, what's this going to cost?" And I couldn't give him the answer, and my administrator couldn't give him the answer. The manager couldn't give him the answer, and so I just thought, well, this is really odd that it's just there's such a lack of transparency. And then when I did see some of those bills coming down the pike and stuff, and the financial strain it put on my patients, I was a little frustrated. And then more frustrated was I as I saw the bait and switch that insurance did over the past 30 years, where they would cover everything at 100%, and then slowly but surely they meet the needs of their shareholders by covering less and sticking in more copays, increasing premiums, and just making it a very untenable situation for local businesses, for individuals and families, and just putting a strain on them and pushing them away from me. With those copays and deductibles, and the new one, the max out of pocket, that's one of my favorites. We have a low copay, but your max out of pocket is still $7,000.
Right.
And so they just play these games and these gimmicks with my families. And my why, I mean, the reason I went into medicine is because I like people, I like caring for people, and I enjoy delivering their babies and watching them grow up and taking care of them out on the sports fields, and taking care of mom and grandma and all that. And when you create obstacles to my why, you start to frustrate me. And so, about 2.5 years ago, I stepped off of the insurance bicycle, and I just did this affordable, transparent membership model. And a couple of my buddies were doing it, and I was like, that's pretty cool. And I've been super happy. I feel like I can deliver the kind of care I want to deliver, spend more time with my patients, get to know them better, and be way more affordable and transparent with all of my transactions with them. Super great.
I love it. What a wonderful story. And I love the backstory of a direct primary care physician, because you guys all have a little bit different a story. But It's the same concept. You didn't really like what was going on in traditional medical practice. And I can tell you, and maybe Janet can speak to this, that, I can honestly say most physicians that are in traditional medical practice, they're just not happy. And I will say that all is a powerful term, but I will say all the direct primary care doctors that we work with in talk to on our podcast or work through our pharmacy, I mean, they're just all happy, and because they have autonomy, like it sounds like you do. So thanks for sharing that story, and thanks for not quitting medicine. We don't want to lose good doctors like you, and unfortunately, there's a lot of doctors that just quit medicine because they get tired of it, right?
Yeah, no, that's totally true. To speak to your point, these I don't know if you can see them, but these smile wrinkles, they're now more of a permanent thing in my life.
I love it. I love it. That is awesome. So you spoke of transparent pricing, and we talk about this on this show all the time. And isn't that frustrating how, I just did a recent post about, make sure that your doctor knows what the prices are of the goods and services that he is recommending, whether it be a referral to a specialist, whether it be an MRI, whether it be a medication. They should at least have some kind of an idea. And you're telling me that they don't. And here's the interesting thing is you can call the administrator, you can call whoever, and they're like, well, what would it be for a total knee replacement? Oh, well, we don't know. It depends on how the doctor codes it. And to me, that is just crazy. And they say it's too complicated. But anyway, if you could give some insight on that, we would really appreciate it.
Yeah, one of the things that we do as direct primary care doctors is our relationship is aligned completely with our patients, and so financially and from a healthcare standpoint, and so we're the best advocate for our patients, and so from a financial standpoint and from a healthcare standpoint, we try to do the right thing, and so so we can go out and negotiate pricing for our patients. Like I have a local imaging center. In fact, I have 2 or 3 because it's you got to go out and negotiate it. So
right. It's great.
I talked to the owners of each of them and said, hey, I've got this direct primary care practice, Voyage Direct Primary Care. What can you do for my clients? And they gave me cash pricing. That's amazing. And they love dealing with that just the cash price of things. And imaging centers, colonoscopies, mammograms, labs. Oh, the rates that I can get on labs are ridiculous. Like it's so cheap to get a full panel of blood work, like the typical wellness panel that we'll order on somebody, check their thyroid, cholesterol, kidney, liver, and electrolytes, blood counts, and screen them for diabetes is like $25. And so, when you can beat copays and deductibles consistently just by going out and advocating for your patients, it makes you, it just feels good, because I like to deliver great care, but I also like to get good pricing on things. And so, yeah, it's fun.
So Janet, do you have some questions for Dr. Sanders?
Well, I just want to comment. First off, I always go to our clients that we're going to interview to their Facebook. And the first thing that caught my eye is what the patient-client experience should be and what people don't like about their current status of their visits. And so I think people think that this is not possible any longer to have time with their provider. So I would like you to tell us what experience your clients should expect at your direct primary care office.
Yeah, and this is pretty universal across the board for DPC practices. Easy access. So they, in fact, just now I answered a text from one of my mamas who has a question about one of their kids with a rash, and so just easy access to that. And so if I don't have to bring her and her other 4 kids in, I could just handle it with a quick text and a call and a video chat if needed. So that's really fun. Just the convenience of the accessibility of those care pieces. The other piece is when you do come to the office. I just did a podcast not too long ago about why docs don't listen, and part of it is because we're on this broken bicycle trying to deliver healthcare to families, and it's very inefficient. It's just super inefficient, and it comes with a whole big bureaucratic load and box checking and paperwork and all this stuff that has nothing to do with A to B, right? Delivering great care to people. And so, so it's fun. Like here now in my practice, I spend an hour with new patients, get to know them. I get to know their kids. I know their names. I know what they like, their hobbies, their interests, and then follow-up visits are often, if it's quick and easy, 15 minutes. If it's a longer deal, then we could go 30. So anywhere from 30 to 60-minute visits are typical here at Voyage. And it's beautiful care. It's relationship-driven care. It's high-touch, high-quality care. On the insurance bicycle, the broken bicycle with square wheels and all kinds of inefficiencies, it became impossible to do that. I have to hire 3 different full-time employees just to interface with that monster, and it only paid me a part of the time, and
Right.
and then it stung people away from me, right? So when they come in to see me, they got a copay, they got a deductible, and so when I want to follow up with somebody, they think I'm just after another copay, and I'm like, no, like this is a legitimate issue, and I do need to see you back in a week or two and talk more, and so now with Voyage Direct Primary Care, I can just talk directly to them, and they don't mind coming back or shooting a quick text or a quick phone call in a week or two and letting me know how they're doing.
So if I was going to summarize this for patients and clients out there, is that you actually have a relationship that's being built between the two of you. So as you are going through life, when things do come around that you need to address, you can have communication together, right? Not between whether I can afford to go in and see him because this is going to be, way too early for my insurance to cover, or I got screened at the front desk and I can't get past that person. And what if this is important and what if it's not?
Yeah, and there's little nuances to care. I love training medical students. I've done it for 10 years, and I'm always teaching them about the art of medicine. And there's little pieces of healthcare that they're not book knowledge, right? And so that relationship piece of the equation is super important. Let's just talk about telehealth, for instance. If you're trying to get a hold of a telehealth company to see if they can help your kid with this thing, right? Well, that seems like it's healthcare, right? That seems like it's an okay thing, right? I pay this, my employer pays for this telehealth company to come and take care of my people. But it's so different when it's a family doctor who knows that kid's name and has done an exam on them in the last 3 months and knows you and knows how you think and how you interact with your children. And so that telehealth visit just went up, 10 points on its efficacy. It's just way better and way more reasonable and just better care, from a doc that knows you, has a relationship with you and your kids. Easy to communicate and to say, my daughter has a sore throat, what should I do? Just a lot easier.
Well, and go into the history a little bit about telehealth, because DPCs like yourself have been doing that for years, but traditional practices really only started because of COVID, mostly. Is that correct? There's been some specialists like, nephrologists and stuff that would do a lot of telehealth stuff. But other than that, general practitioners or family practitioners didn't do that. Will you tell us some of the history there?
Yeah. Traditionally, we just didn't, it was not a service that was offered because, again, it was not transactional enough and insurance companies didn't pay for it. And so it was a transaction. And so in order to take care of somebody, I needed to bring him into the office and collect a copay, do that whole ball game. Well, in an innovative model like direct primary care, where you just have an annual subscription, it's much easier for me to just be available and say, oh no, this is something simple and easy, and we can take care of it on the phone. And especially if I know that family, the corporatization of medicine has been one of its downfalls, and in my opinion. And so you have these big corporatized models that their bottom line is revenue, and so they're trying to balance the utilization and all those things. And in a telehealth product where your employer provides you with a telehealth product which is staffed by random people that you don't know, they're banking on the utilization being very, very low, and they're banking on a product that's not awesome either, right? And so then your utilization is even lower. Whereas in DPC, we over deliver healthcare. It's not uncommon for people to access way more care than they pay for per year. And I'm totally okay with that. And so are my colleagues, because there's been such a paucity of really great care in America in this third-party payer system model. And so we're able to fill those gaps. And I've got so many stories of families who, I just haven't been into the doctor for 5 years and they've got this thing. And I'm like, holy cow, huge
Yeah.
deal. Like you should have had addressed a while ago.
So basically what you're telling me is that with telehealth, the reason it didn't happen before was because doctors wouldn't get paid because insurance companies wouldn't pay them. So, and you also mentioned, a few minutes back about payments from, doctors. Patients maybe thought that doctors would want patients to come back in just to get another copay, and maybe it wasn't a personal issue for the doctor, but if that system is getting paid, then and that's how they got paid, they are incentivized by having a patient come in for another visit. Is that correct?
Yeah, that's right. That's how they get paid. It's throughput, it's transactions. Yeah.
So there are, I guess what I'm saying is there are health systems that will, do follow-ups that may or may not be necessary, but if Medicare pays for that diabetic to come in every month, then they'll have that diabetic come in every month just so they can get paid. Is that true? Is that true sometimes?
Yeah, I don't know about that. I don't know. I think that when there are systems like this that are inefficient and frumpy,
Right.
There's bound to be some abuse situations going on. It's more of a game than it is care. And so when you're trying to game systems, you're trying to, what are they going to pay for? Well, we should.
And that's where I was going at, really.
Yeah.
Right. It's just a game. And I think healthcare providers that play the game, I mean, they're kind of accessories to the crime. And I'm actually quoting Dr. Keith Smith from the Surgery Center of Oklahoma when I say that, because he's the one that taught me about that. And I used to feel guilty about telling my colleagues, well, you guys can't help it. You guys are stuck in a system. But you know what? We had a DPC on a few weeks ago, and he decided in order to change the system, he had to get out of the system. And I'm with you there. I don't think you can play the game, because if you end up playing the game, the patient loses and the healthcare provider loses.
Yeah, it's super frustrating, and it's not true to our why. Our why is care, and we just got to stay on that vein. And I think that's why that's really the foundation of direct primary care. We just want to help people, and we want to deliver excellent care to them. And when we contract with a person directly, there's a direct relationship, and there's no conflicts of interest, and there's no games, and there's none of that. It just cuts out all that silliness and puts beautiful care back into the equation. House calls as needed, telephone, video chat with your doc. It's beautiful. It's beautiful care.
No surprises either. No surprise billing.
Yeah.
Right? Yeah. I mean, it's all transparent. I love it.
Yeah.
I mean, kind of how a free market should work is that consumers know what they're paying. They know what they're getting. And you know what you're getting too. And of course, you as a doctor is really incentivized to make those people happy because they're the ones that pay you. We're in a third-party model. Sometimes doctors aren't very happy in those models. The system is like you say, broken. So the consumer is actually the consumer, the payer of the bill is actually the third-party insurance company, and sometimes that might not be why you get the best care.
Yeah, can I just share a quick brief story about?
Please, we love stories.
So there's a family that engaged with me a while back, and they're very natural, very holistic people, and I love them. I grew up that way with herbs and poultices and all kinds of groovy goodness. And it just, over time, I got to know all their kids. And one day they brought in one kid that I hadn't met yet, and she was coming in because I'm an osteopath and I do musculoskeletal things all the time. And I was doing an adjustment for her, and I saw this kid, and I said, "Holy cow! I'm going to pause our visit today with mom, and I'm going to just address this kid." And I spent an hour and 15 minutes asking questions and diving into his details. And he was sick. You can tell when a sick person walks into your office, you just know all your red flags go off and all your spider senses and all that. And
how old was he? Sorry to interrupt, but how old?
Yeah, he was 13. He
13?
hadn't grown in a couple of years. He was profoundly anemic just on physical exam. And So I just talked to him, and after asking a few more questions, I said, well, there's something going on. And on my exam, he had this abdominal mass, and I thought it was cancer, and it was terrible. But we did some tests, and we did some ultrasounds, and all very affordably. Ultrasound was like about $160, and the tests were like $25, and we were able to pull from just a little bit of money, just pull out a good diagnosis, and it ended up having a stage 3B renal failure. He had hydronephrosis. He was profoundly impacted and he had a pretty rare syndrome called Hinmans syndrome. And so I sent him to the University of Utah, the urology department and the nephrology department. We had to disimpact his bladder and his bowel and kind of just reperfuse his kidneys, and his kidneys came back online and are doing much better now. And I just worked with these specialists, right? And so direct primary care doctors are not all cowboys, but we take good care of people. And so I worked with the nephrologist, the urologist, and the GI doc, and we got this kid the care that he needed, and really saved his life. I mean, I think he would have been in just catastrophic mode in the next few months, and so. It's just those kinds of things, because I was able to recognize a situation. In a fee-for-service thing, there would have been blinders on, right?
Absolutely.
So,
absolutely.
Your mom, there's nobody else in this office, and it's just you. And I see your kid over there that's really sick, and you should make an appointment for him in 3 weeks when I can get him in and spend 5 minutes with him, not asking questions. And so it's just a good manifestation of how we can pair with this current system and work with these specialists and work with these guys and these folks, that because DPC is not specialty care as much as it is primary care, right? Direct primary care. So the family medicine doctors can tie in directly with their patients. Well, all along the way, mom would send me texts and emails and phone calls about how things are going. And I was there for her every step of the way as this kid was getting worked up. We went from super scary, this kid has cancer and is going to die, to, oh, it's just a pretty rare Hinman syndrome where he's got impaction of his general urinary and GI tract. And so anyway, he's doing great. I just saw him last week, and he's no longer anemic, and he's growing, and he's doing really great. And so it's just
great story.
Yeah.
So Janet, as a mom, do you have any comments about that story?
Well, I do, because it brings back to me some childhood memories of our family physician. And I think as Americans in our culture of healthcare, we have forgotten what that was like. Our family physician knew us probably from the time we were born until we died sometimes. And I remember, even just as an athlete in high school, our physician being at the games, and if you had a sprained ankle or an injury, he was there, and the next, he walked you through everything. And I think those relationships are being rebuilt again in the DPC model. And I noticed that you like to handle sports injuries and injuries. So would you like to share a little bit about the why and how you like to dive into that in your practice?
Yeah, sure. I love what you said about bringing back old school principles and caring for these families. And I get that a lot. Actually, a lot of my families will tell me, it's like the way medicine used to be.
Right.
Yeah, it's beautiful. It's good value care. It's awesome. No, yeah. So sports medicine, I've always loved sports. I play a lot of sports. I play a lot of pickleball right now, but I grew up playing basketball and football and rugby in college and volleyball and soccer. Super fun. So I've always had a special affinity towards sports and towards treating athletes, and understanding what it means to be, benched from a concussion or from a shoulder injury. And so I can help them out with a lot of those things. No, yeah, I love sports injuries. Is there anything in particular you want me to talk about today at all?
Well, I know you just made a wonderful video on plantar fasciitis, and I think many of us, including, I'll speak for myself, have been affected by plantar fasciitis. So, and it's not just a sports injury, if I'm correct, but it is caused many times by, overuse in a sport. So if you could talk about plantar fasciitis, that would be great.
Yeah, for sure. So many of my pickleball buddies have suffered with plantar fasciitis, and like you said, there are some people that don't love pickleball that also suffer with it. Yeah, so plantar fasciitis is if this was your foot, this would be the bottom of your foot, ankle, and it's kind of like from the heel to around where the toes are, and it's that bottom of the foot, super painful, super inflamed, and the classic presentation is I roll out of bed and I go to walk, and those first, I don't know, first 5 steps are just like fire on the bottom of my feet.
In there.
Yeah, me too. Me too.
Oh, I mean, it's like a knife is stabbing you.
Yeah, super painful. And it's often caused from flip-flops, bad shoes, not enough support, and that plantar fascia just has to constantly move around on that less supported shoe. Sorry, this camera angle is weird. And so it just becomes unstable and causes a lot of motion in there, and then creates inflammation chronically in that area. Super, super painful. And the fix is to try to get a better shoe system. I like stability shoes, especially if you tend to be a pronator, where your arches aren't really high and rigid, but they tend to just push in just a little bit. That's super helpful to have what's called a stability shoe. All your major brands make a stability shoe, and they'll just hold that. They'll hold that talus and calcaneus in a stable position, and really the back 2/3 of your foot, they'll hold that into a really stable position so that it doesn't move as much. And so then it lets that plantar fascia heal up. And so that's super helpful. Arch supports are great. And I like a good stretching regimen and even icing while you're trying to acutely manage that thing. It's
Acutely, right. So I got to tell you a quick story about plantar fasciitis.
Sweet.
And not just good shoes, but wear the good shoes all the time. Don't go around barefoot, right?
Yeah.
And I was guilty of that. And I was walking barefoot on a tile floor, and I was overweight at the time. So that it just exacerbated it. But I got to tell you a story about my 3-year-old son. So he had what I assume was plantar fasciitis. His feet kept hurting. So I said, well, you need to wear your shoes more. He's going on barefoot all the time. I said, you need to wear your shoes more, you know? So one day, his older brother comes in to me, and Janet and I, it's bedtime. Janet and I are in bed, and his older brother says, Dad, you have got to go talk to Jordan. He is wearing his shoes to bed. I just told him to wear his shoes more often. I didn't tell him to take them off at bedtime.
He
So
was
anyway,
listening to you.
yeah, he was listening to me. It was a hilarious story. And by the way, he is 18 years old now, and he is the one that will be editing this video. So he'll hear our conversation. And it was hilarious. I mean, Jan and I couldn't do anything but laugh. I mean, we really had to smile about it.
That's so funny. It's interesting because one of the things we do with plantar fasciitis is sometimes at nighttime when you sleep, your foot does this, right? And then that plantar fascia starts to just kind of stay in that position and get really tight. And then in the morning, when you go to step down and it stretches out, it feels like fire. And so one of the things that we'll sometimes do is put somebody in a brace to brace their feet like this. And so, maybe sleeping in the shoes was not
right. That's true. Right. Yeah, they call those night splints, right?
Yeah. Yep.
Yeah. I've seen those. We've worked with some podiatrists with those before when we used to do medical equipment. So yeah, that's a great one. So another one, and I've actually been affected by this too. I'm a competitive mountain bike racer, and I'm on my bike a lot. And so I get IT band tightness and some hip flexor tightness. So I don't know if they're treated the same or those be treated differently, but I know runners get a lot of IT band tightness. What are your thoughts about that?
Yeah, the bikes, cyclists, runners, even athletes of any kind. Like man, that lateral side of your thigh can get just super, super tight, and it can start to pull your patella over. All your quad, right? Your quadricep is the front of your thigh. Those 4 muscles create 4 tendons that form into one, and then they encapsulate the patella, and then they go in to insert on the tibial tuberosity of your tibia. And so if your lateral thigh is really tight, it can actually cause that patella to track off center, and can cause all kinds of problems and pain. Yeah. And so, yeah, rolling out your IT band and your lateral thigh and lateral quad is super, super clutch to that. They have those, you guys have probably seen those little like hyper ice, like the massage guns and stuff. They have a whole bunch of them out there, and they have some pretty cool little units and things like that. And so stuff like that's really great. That you got the foam rollers that people roll on and stuff.
Right.
If you want to like inflict a lot of pain, that's how you do it.
Yeah, it does hurt for
Always a
sure.
training process.
Yeah.
Yeah.
And then, so to prevent that, what do you need? You need to strengthen your inner glutes or your inner quads. Is that correct?
Yeah, I don't know that it prevents it. You still just got to stretch and warm up and do all those things. But strengthening the VMO will definitely, this medial thigh will definitely help with the tracking issues of the patella and any pain that you might develop down in that area. And yeah, I would just get a bunch of, like, we call it the VMO, which is like the medial thigh exercise regimens. And there's like, it's the last 30 degrees of extension if you're doing squats. And so just do baby squats instead of full squats. And then there's a couple of other leg lifts and isometric exercises and stuff you can do to kind of strengthen that medial thigh.
Well, and that's why you're not using those auxiliary muscles as much, those smaller muscle groups. So that's why they're getting weaker, and then you start having problems, I'm assuming, right?
Yeah, so you're jumping, sprinting, cutting, bursting, cycling. It's all lateral thigh and it's really strong, big muscles. And so it, you got to strengthen that medial thigh too. Right. I made that mistake. I'm a weekend warrior. I play tons of sports and I don't work out as much as I used to. And so I started having some patellar tracking issues and some IT band tightness and all that. Yeah.
Yeah. Cool. Well, thank you for that. By the way, for you, Dr. Sanders, and for our listeners and viewers, we are going to put some 1-minute videos out of this. So stay tuned. If you guys didn't catch that, we'll have a little 1-minute segment or a couple minutes of the videos that he talked about him treating each specific athletic injury. So what's the next one we're going to talk about? Tennis elbow, pickleball and tennis elbow you talk about quite often, right?
Yeah.
And why is it called tennis elbow? Let's just go into that first of all.
Yeah. Just lateral epicondylitis. It's right here. Just the lateral epicondyle. It's your wrist extensors. They all insert right there. So if you were to move your wrist out, I can't do it both at the same time, like this, then you would feel it right there on that lateral epicondyle. Dr.
Sanders had to step out for just a minute to see a patient, and then he will be back and he will finish up talking about tennis elbow. But while we have some time, I wanted to discuss my most recent experience with Christian Healthcare Ministries. As you guys know, and that have followed this podcast and followed us, you know that we have a health sharing ministry called Christian Ministries, and we do not like the traditional health insurance model. We've told you many times how we didn't have good experience with it. Many of our patients don't, just like Dr. Sanders was talking about earlier. So, but let me tell you what our most recent experience was with Christian Ministries. So, as you guys know that are following the story, my son broke his leg in May. And Christian Ministries, we submit the bills. We're self-pay. That means we pay the hospital, and then Christian Ministries, through shares of other people that pay a monthly membership fee, pay us back. So, and Christian Ministries was on it right away. We shared the bills with them to the hospital, and they were ready to pay very quickly, probably within about 30 days. They're ready to write me a check, but I was negotiating with the hospital to get the best possible discount. So I did negotiate a price, a discount with the hospital of 20%. I don't think that's enough. That's a topic for another story. I will report on that later, because it still was over $38,000. And for the same surgery, I could have got Surgery Center of Oklahoma for $8,000. Still way overpriced. But Christian Ministries was awesome about it. And we have the bronze plan, which means we have a $5,000 deductible. It's not really deductible because it's not insurance, but we're responsible for the first $5,000. So, but here's the beautiful news of that is with Christian Healthcare Ministries, if you negotiate any kind of discount, they take that off your deductible. So because the bill was originally $47,000 or so, my discount of 20% was like a $9,000 discount. So I ended up not having to pay the $5,000 deductible. So it ended up costing us nothing directly out of pocket. That's how Christian Healthcare Ministries works. No insurance company does that. No insurance companies emails you 3 or 4 different times and communicates with you saying they want to settle that payment. Insurance companies just deny payment on and on again. So I was very, very happy about that. I'm going to write up that story also in a Facebook post so you guys can know more of the details, but I was super excited about it. Health Sharing Ministries work. If you don't believe it, there's a great story of one. So they sent me, when I finally authorized the check to be paid, when I said, okay, we're ready to be paid, I authorized it on a Friday. We received a check the next Thursday for the entire amount. Health Share Ministries work beautifully. We've had the same result with Samaritan Ministries before also. So go check them out. They're not all faith-based either. So we've interviewed actually New Health, KNEW, on our show. Had a podcast with them on here, and they tell their story too. So they're all a little bit different. They're a lot less expensive than insurance, and they work. Janet, do you have any comments about that?
I do, because as we keep moving forward and we keep talking about DPC models and sharing ministries, I think as we, as consumers of healthcare, are able to have a say in the matter, I believe that this is probably one of the directions that we're going to go in this country. And it does give us the freedom to choose our providers at their level of expertise and what comfort level we have with them as a provider. Dr. Sanders is a perfect example that, his clients choose him for his knowledge, as his bedside manner, and how he can interact with them, and we're not being dictated to by a company. Big insurance companies do not care if you have a good relationship with your primary doctor. That is not their motive, and I'm not trying to vilify them in any way. It's just the facts. If you have a provider that you can call up and text and say, is this important or not? And you work with this person over the years, then if something comes up, like the child that Dr. Sanders talked about, that something hit him right through the child walking through the door, he addressed it immediately. It wasn't a question of whether this person was covered or not. He knew that this child needed some assistance and help, and he was able to practice. And I think the other side of the coin is healthcare providers are usually very silent in this process, and they just accept that, I'm just stuck here. This is where I have to be. This is how I'm getting paid, and this is just part of the drill. And I don't buy that for a minute. Shawn and I made decisions and choices in our career path to go with a cash system, and it has forced us to be answering to our clients up front, because we have that relationship with our clients. And it also has been a journey of not just faith, but also a journey with our clients in their health and wellness. And there are many DPC models out there. If you are just saying, I've had enough, I can't see 20 more patients in this amount of time to make that work for me any longer. I don't see my family. The pressures are, next. I don't have real good communications with my clients. If you're giving your people only 3 questions to ask when they come through the door, and you're seeing them for 5-10 minutes, and that's how you want to practice, fine. But if you don't, there are choices. And I believe that the more we as professionals take a stand and look for something that's going to give us back our why and our purpose of what made us choose healthcare, and offer solutions to patients and take care of ourselves, and then we will be better providers too. And I really believe this movement is growing. When we first took that leap of faith and just went cash, that's been quite a few years ago.
2002.
And people said, you'll never make it. Well, I can honestly tell you, it wasn't just, we made it financially, but we also were able to make better choices for our family and our clients and our patients. And so I just want to encourage you. There's many people out there, if they're in a DPC model, I'm sure Dr. Sanders would be welcome to this. I know we had a gentleman on last week. These other providers will take the time and help you. All the time when Shawn is researching for podcast clients or people to interview, we see more and more providers out there, whether they're nurse practitioners, MDs, specialists, that are jumping. They're saying, you know what, there's a better way to do this, and I want to take care of my clients, and I want to find a way to do it. And once they have connected with some people, they get the skill set, and they're taught how they can do this, and it's possible.
Absolutely, it's possible. And, you know, we're an example of that. And we're just a one tiny example of that. We might have been a little bit ahead of the curve. And like Janet says, in 2002, when we took the leap of faith and we stopped billing insurance, there were a lot of doubters, and including people in the medical field. In fact, most in the medical field, but even friends and family too, even employees that said that we couldn't do it. And here we are 18 years later, and we're doing better than ever. Now, it's not that there's not struggles, but not only do we feel that we are able to give better, not only do we like what we do better, but I think our patients like it better, because we're able to give them better service at a better price, and transparency, just like Dr. Sanders was talking about early on in this podcast, is that, you know, we don't have to hide behind what kind of cost something's going to be. We know exactly. We will, you know, if you call us, we will tell you. We're a big believer in the free market. I'm a big believer in all kinds of free market, including healthcare. And my book talks about it. So my book, Sickened, How the Government Ruined Healthcare and How to Fix It, is available on Amazon, Kindle form. And really, it's free market principles. It's a transaction between you and your healthcare provider. You knowing what it costs, they knowing what to charge you, and there's no secrets, there's no surprises. And when it's transparent like that, things get less expensive, and the service is better. So, you have something else to say about that, Janet?
Well, I think if you're doubting it and you are in the healthcare, the Oklahoma Surgic Center welcomed us with open arms, and Dr. Keith Smith took the time to even show us around. And, you know, I can't tell you, I don't think I've seen happier staff in a surgical center. And I'm not saying that people don't like their job or like helping people in a hospital setting, in a clinic setting, or a surgical setting, but the pressures are different. You're not being stuck to somebody else's regiment. You're able to perform at the level you are gifted to, and people become people again and not numbers.
Yeah, that's absolutely true. And if you ever get a chance, check it out. Check out the Surgery Center of Oklahoma on the internet, or better yet, go down there and tour. We did have the opportunity to do that, and it was a wonderful blessing. And we just realized even more so that we're doing the right thing. Free market healthcare is I think the future. And I think the future, and you, the patient, are in charge of that. Realize that you don't have to accept the healthcare you're getting now. If you don't like it, then change it. Oh, you say, well, you know what? My employer has this health insurance for me. Well, first of all, let me tell you, most of the times, health insurance is a ripoff. You are better off paying cash than you would be if you use your insurance. Here's a good example. So, Dr. Sanders, he can get an MRI for $360. I talked to somebody the other day that through their insurance, their copay was $400. Yeah, it was covered all right. They paid more than they would have paid for if they paid for it than if they would have paid cash. Medications are that way all the time, and they limit you too. Not only is it not timely, they limit access with time, or they limit you to a 30-day supply with medications. And that might not be the most affordable or the most beneficial for you. So, you know, one of the things you can do, and one of the fixes in my book, I'm not going to give away all my book. You got to read it to do it, but you're in control. Remember that. And requesting cash services, that's part of the fix. And another thing is part of the fix is, you know what? That insurance, look at what an employer pays for your insurance every month. It's upwards of $1,500 to $2,000 a month. You really don't get that, and you really don't get that back. Hardly anybody gets that back. So negotiate with your employer. Say, you know what? I don't want this health insurance. It's not worth it to me. I want more money, or I want more vacation, or whatever. Negotiate that, because that's how this problem is going to get fixed. Because right now, the hospitals, the big healthcare entities, they're in bed with the insurance companies. They have got a scam going on, bigger, so big. The biggest lobbyists in all of the country now are in healthcare now. They're the biggest lobbyists around. Bigger than big tobacco, bigger than the gun lobby. It's the healthcare lobby, because they make billions of dollars, and they want to hide behind non-transparent pricing. That's what hospitals want to do. They don't want to be transparent, because they realize then consumers will realize that they're getting scammed. They're getting ripped off. So, check out my book. I think you'd learn a lot. We're going to have to invite Dr. Sanders back again, and he can talk about tennis elbow, and specifically what that is, and how to fix that and treat that. So we appreciate having Dr. Sanders on today. You do not want to miss Thursday's episode, something different than we've ever done before. We are having somebody that's in recovery. They were recovering from drug addiction, and they are going to share their story. I'm super happy that he's excited to share his story. He's shared it a lot with a lot of people. He's also now a recovery coach, and I'm super excited to have him on. His name is Joseph Hunter. I'm super excited to have him on Thursday. We will be streaming 8 to 9 in the morning, Pacific Standard Time, and you don't want to miss that. So you've been listening to Health Solutions with Shawn and Janet Needham. Tune in Thursday. Thank you for listening and viewing. Thank you so much.